All right, thyroid hormone. So again, thyroid hormone is T3 and T4. That's specifically what is released by our thyroid. It is a fat-soluble amino acid hormone that is released from the thyroid gland. T3 is our kind of our physiologically most active form. And T4 is kind of our precursor form that's not as active, but makes up about 90% of the thyroid hormone that's in our blood. So anytime we talk about thyroid hormones, we are talking about T3 and T4 combined. You've probably had lab tests where someone has said, we're going to check your thyroid, and they do a TSH, and they do a T3, and they do a T4, and how much of this is floating around, and what are the percentages of it. And what they're really looking to see is thyroid stimulating hormone. Is the pituitary functioning the way it should to tell the thyroid gland what to do? That's the TSH. And is the thyroid then responding appropriately by producing T4? And are you then converting the appropriate amount of T4 into the active portion, T3, so that your cells can actually be stimulated appropriately? So the primary effect of our thyroid hormones, our T3, T4, is that we are stimulating or increasing the metabolic rate of our target cells. It's going to stimulate our sodium-potassium pump. It's going to make our cells more responsive to the catecholamines. So this is why it's kind of associated with energy and et cetera. And it's necessary for kind of normal growth and development and for the function of growth hormones. So you need these hormones in order to develop normally and to have kind of normal energy and metabolic processes throughout your body. So again, thyroid hormone is a negative feedback loop. We kind of covered this briefly at the beginning, but the hypothalamus secretes the thyroid-releasing hormone, which affects the pituitary, which releases thyroid-stimulating hormone, which affects the thyroid gland, which then releases the thyroid hormones, T3 and T4, which affect the target cells in the rest of the body. So we kind of have this process. And along the way, when we reach what our kind of goal range for any of these hormones, it's going to send a message back to the gland above it and say, oh, don't really need any more, so you can stop stimulating me. I'm doing fine. When we're checking labs for people, how do you know where the problem is if they've got a thyroid problem? So they come in, your patient's got low thyroid. Well, where's the problem? Is it the problem in the thyroid gland itself? Is the problem in the pituitary gland? Is the problem in the hypothalamus? And how do you know? And the answer is it can be any of them. It really depends where the origin of the problem is. Do you have a pituitary tumor that's causing you to secrete too much thyroid-stimulating hormone, and so you've got a hyperthyroid state? And the way you can tell is that you want to look at the labs and where the levels go off, and that's going to tell you at what level is this thyroid problem occurring. I think on the next page, well, we'll get to it in one moment. So thyroid hormones, T3 and T4, the interesting thing about T3, as we said, it's our most kind of physiologically potent form of thyroid hormone. There's T3 and RT3, which is called reverse T3. And reverse T3 is literally what it sounds like. It's T3, but it's reversed. It's structured a little bit differently. The interesting thing with this is that when we do that, you can't use it as well. So we've changed the structure of the T3, and it actually does not function in the same way. And so you could have normal levels of T3, but actually be clinically hypothyroid because it's not the right type of T3. So it's just something to be aware of if a patient is exhibiting all the signs of hypothyroidism and you check their thyroid levels and, well, gosh, gee, it looks normal, they may still warrant a trip to an endocrinologist to see, well, maybe they're not producing the right type of T3. So when we metabolize T4 to T3, there's 3 different ways that we can actually metabolize it. One is glucuronidation, which I can't pronounce, sulfation, but the primary method is actually deiodination, which is essentially you're taking away an iodine molecule from T4 and it becomes T3. So you take away this one iodine molecule. Depending on the way that you take away the iodine molecule, whether you take it away from an inside ring or whether you take it away from an outside ring, is whether it's regular T3 or whether it's reverse T3. So that is actually how you take away your iodine molecule affects whether or not you can use your thyroid hormones. When we look at a picture here, this is just showing the kind of the deiodination of T4. So if you go through the first pathway of deiodination, you'll make both T3 and reverse T3. If you go through the second pathway, you might actually only be making regular T3, and you might be getting reverse T3 that's going to T2. This slide's a little on the complex side. So again, I don't want you to memorize this. It's just a little bit of information. But I do want to show you the chemical structure because it is actually fascinating to me that a simple change in where you take the iodine from can determine whether or not you can use this thyroid hormone. So T3, and also the interesting thing is that the conditions under which we make T3 versus reverse T3 have to do with kind of how our life situations, what's our nutritional state, what's our stress state, how much iodine do we have, et cetera. So when we have abnormally high levels of cortisol, so stress type states, or we have vitamin D deficiency, or we have iron deficiency, we're actually going to make higher levels of this kind of bad T3 that we can't use. So we're making T3, it should be active, but we really can't use it because our body's in this kind of hyper-stress state. When we're not in this stress state, we're actually making better quality T3, which is the regular T3 that we can use. So looking at these pictures, and this is just a picture, the top one is T4, and those little red balls are the iodine molecules. And you'll notice that T3, which is on the left-hand side, has one iodine molecule there in the center ring, and reverse T3 has one iodine molecule on the outside ring. So that the reason they call it reverse T3 is you simply took the iodine molecule from the wrong ring. That's all that happened. So you can see that it's a very small change in your body, but it actually has very significant implications. You take the iodine from the wrong place, guess what? It doesn't work right. Conditions that cause basically low cellular T3, essentially cellular hypothyroidism that are not going to be detected by TSH levels, is going to partially be this production of reverse T3. So if you have all this reverse T3 in your body's going to think, well, I have enough thyroid hormone floating around, so I can stop making more. So you don't have elevated TSH in patients who might have this kind of cellular type of hypothyroidism. So their cells can't use the thyroid hormone that they have, so they're hypothyroid, but your body thinks you have enough, so it doesn't make more TSH. So it's kind of a little bit of a paradox there. It's like being tricked, thinking that you have the real thing when what you actually have is something that doesn't work very well. So in fact, go ahead. So yeah, basically we're just testing for T3, T4, and thyroid stimulating hormones. So you can be like, oh, your thyroid levels are fine. But if I had someone who really was exhibiting clinical signs of hypothyroidism, I might be a little bit suspicious and say, why don't we just send you to an endocrinologist and see if there's anything else that they can look at. I'm actually not sure how they're testing for the reverse T3, and that would be an interesting thing to look into. If there's a specific clinical laboratory test for, there's got to be. But currently that's not really what we're doing in clinical practice. But it's just kind of worth being aware that it's not a 100% test, what we're testing for. So factors that inhibit our hormone production of our thyroids is going to be things like stress, trauma, infection, because those are stressful types of states, toxins, so our heavy metals are autoimmune diseases. And then we have factors that increase the conversion of T4 to the reverse T3. And that's going to be, again, stress, trauma, inflammation, toxins, certain medications. Keeping in mind that we need certain nutrients in order to produce our thyroid hormones, and that's going to be our iodine, obviously. People who were in low iodine places, that's why they would develop the goiters, because the thyroid tissue would hypertrophy in an attempt to produce additional of this thyroid hormone, but it doesn't have enough iodine, so it just keeps getting bigger and bigger. So that's why people would develop these goiters in low iodine states. Zinc, selenium, a whole list of vitamins, B vitamins, vitamin D, vitamin C, vitamin E. If we don't have these, we're not going to be producing our thyroid hormones appropriately, or we're going to be converting more of it over to reverse T3 than we should be. Causes of hypothyroidism. I don't remember putting a moving turtle there, but what do you know? Okay. I must have borrowed this slide from somebody else. So primary hypothyroidism, Hashimoto's, that's an autoimmune thyroid disorder where the antibodies are essentially attacking the thyroid gland and killing it off. We can have a subacute thyroiditis, again, an inflammation of the thyroid gland. We can have iodine deficiency. So people who live far away from the ocean and don't get enough iodine in our diet, that's why we now iodize our salt to make sure that our population gets enough iodine in their diet, and it's a simple method by which we can prevent iodine deficiency. You can get infections of the thyroid gland. You could have a thyroidectomy, so somebody had hyperthyroidism previously. We go in and we remove a chunk of the thyroid gland, and now you're hypothyroid. You could have had radioablation. Again, same thing. We needed to destroy part of the thyroid gland. We've destroyed more than we necessarily needed to, and you're now hypothyroid. We could have medication exposures. Top two causes are autoimmune and congenital. We don't see as much of the congenital hypothyroidism as we used to, and that used to be called dwarfism or cretinism because when you take away the hypothyroidism at this age, you're not going to develop physically or mentally in the same way that you would otherwise develop because of the relationship with your growth hormone. So this is basically you have a child at birth who has normal potential cognitively and normal potential physically. You take away the thyroid hormone from that child, and they are not going to develop. They're going to develop mental retardation over time. They're going to develop physical deficits over time. Secondary hypothyroidism just simply means that the problem does not originate within the thyroid gland itself. It originates a level or two above. So think hypothalamus or pituitary. So that's going to be a tumor. That could be surgery in one of those glands. It could, again, be radiation in one of those glands. Anything that affects whether or not those glands are releasing thyroid-releasing hormone from the hypothalamus or thyroid-stimulating hormone from the pituitary. This is just a little cartoon showing Hashimoto's thyroiditis. And the little guy says, "Thyroid, my liege, the antibodies are mutinying and they're attacking you," sort of thing. And you can see that in the next slide, you come down, the antibodies have attacked the thyroid gland, etc. So that's Hashimoto's. It's an autoimmune version of hypothyroidism because when the antibodies kill off your thyroid, you don't make thyroid hormone. Hyperthyroidism is too much thyroid. And again, we can have primary or secondary causes. Primary being at the level of the thyroid. The problem is within the thyroid. Secondary meaning at the levels above the thyroid. Pituitary, hypothalamus. So primary causes are going to include things like Graves' disease, a thyroid adenoma, tumor of the thyroid. Again, a thyroiditis. So thyroiditis can go either way. Does it make you cause you to make too much thyroid hormone? Does it cause you to make too little thyroid hormone? Do you take in too much iodine? So you're actually making too much of the thyroid hormone. And certain medications can cause that as well. At the secondary level, we would be looking again at an anterior pituitary tumor or hypothalamic tumors. This is just a little cartoon showing the effects of hyperthyroidism, and it tends to be accelerated metabolism, sweating, hair loss, fine brittle hair, racing heart, because again, it's absolutely wildly accelerating our metabolic state and some of our stress type states. Pinpointing your thyroid disorders. This is the slide that I was mentioning a little bit back. So if you're trying to figure out where's the problem coming from, I know I have this patient who's basically not producing enough thyroid hormone. Is it the thyroid? Is it the pituitary? Is it the hypothalamus? You want to actually run a couple of tests, and you want to include thyroid-releasing hormone, thyroid-stimulating hormone, and then your T3, T4s. If the problem is at the level of the thyroid itself, so you can see that up in the top, actually, let's start at the bottom. So thyroid gland, if you're not producing enough thyroid hormone, and we know that the thyroid gland is not responding effectively, you will see elevated levels of TSH, so the pituitary is trying to stimulate it. You'll see elevated levels of thyroid releasing hormone. The hypothalamus is trying to stimulate it as well, but you'll see a low response from the thyroid in that it's not actually making the thyroid hormone. So the first two will be up, and the thyroid hormone itself will be low. So stimulate, 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 but you're not doing anything in response. And you're going to get exactly the opposite pattern for if you're making too much. If the problem is at the level of a pituitary, then you're going to get a low thyroid stimulating hormone with low levels of thyroid hormone. But you're going to see an increase in the thyroid releasing hormone because the hypothalamus is like, hey guys, wake up, do something, do something, do something. But the pituitary is sleeping. So it says, no, I'm just not right now, not really doing anything. So you'll see that the thyroid hormone and thyroid stimulating hormone are going to be low, but the first one from the hypothalamus will be high. If the problem is from the hypothalamus, then everything is going to be low because it's not going to send out any of the initial message through the thyroid releasing hormone to go ahead and stimulate all those processes. So that's how you kind of separate out what's the level of the problem. This is just a comparison of Graves' disease hyperthyroidism versus hypothyroidism. And you can see they're very much kind of opposites. Hot intolerance versus cold intolerance. Cool, dry skin versus warm, damp skin, accelerated metabolic processes. Tachycardia versus bradycardia. They, interestingly, can both be associated with goiter. In one case, goiter from hypothyroidism, your thyroid gland is hypertrophying, it's trying to make more. In the case of Graves' disease, it might be tumor or other reasons for hyperthyroidism causing increased production of the tumor. So silky smooth hair in your hyperthyroidism tends to be very fine, very brittle. Hypothyroidism, it's going to be kind of coarse. Muscle weakness can be present in both weight loss with hyperthyroidism, weight gain with hypothyroidism. Acquired hypothyroidism, what this little growth chart is on the left-hand side is it's showing the point at which a child acquired hypothyroidism and then began to be treated with thyroid hormone and how the growth picked back up. So you can see that when they became hypothyroid, their growth actually leveled out and stopped. And that when they were treated, they kind of picked back up and caught up to that trajectory. And this table just again lists some of the signs and symptoms of hypothyroidism versus hyperthyroidism. Myxedema, you may have heard that term, is an acute hypothyroid state, which is essentially a crisis state. Your thyroid is so critically low that you go into an acute ICU type state. It tends to be associated with a very, very puffy face. All right, let's see where we are. I think we're about halfway at this point. 10:30. Let's go ahead and take a 10-minute break, and we'll resume.